Hi everyone. Imagine you're a doctor in the emergency room trying to figure out if a patient is having a heart attack. What if there was a simple protein test that could help you detect it quickly? Today, we're going to explore how scientists figure out if such a test really works using hypothesis testing. By the end, you'll understand how researchers decide whether differences they see are real or just due to chance. Before testing any new protein, scientists need a structured way to decide if the test actually works. That's where hypothesis testing comes in. In hypothesis testing, there are two main ideas: null hypothesis, H0. This is the default assumption. For our protein test, it says M-izime levels are the same in patients with and without heart attacks. Alternative hypothesis, H1H1. This is what we want to investigate. M-izime levels are higher in patients having a heart attack. Our goal is simple: see if the evidence from our patients is strong enough to reject the null hypothesis and support the alternative. To test the new protein, researchers gather data from two groups of people. Group 1, patients without a heart attack. These individuals come in with chest pain that turns out to be caused by something else, maybe anxiety, muscle strain, or indigestion. Group 2, patients with a confirmed heart attack. These patients show classic symptoms, ECG changes, or other diagnostic evidence. Blood is drawn from both groups, and M-izime levels are measured. Why do we need two groups? Because hypothesis testing compares what we observe to what we would expect if the null hypothesis were true. If the null were true, the two groups should look similar. But if the alternative is true, the heart attack group should show significantly higher M-izime levels. This difference, or lack of difference, becomes the heart of hypothesis testing. Even if the protein test really works, not every patient will show the exact same M-izime level. Some naturally have higher levels, some lower, and timing also affects the value. This natural variation is why scientists can't rely on simple differences. They have to ask, is the difference big enough to be real? Or could it be random chance? To answer this, we use something called the test statistic, a number that measures how far the observed results are from what we'd expect if the null hypothesis were true. Once researchers have data, they calculate a test statistic using methods like the t-test. But the most important part is the p-value. The p-value tells us, if the null hypothesis were actually true, how likely is it to see results this extreme? A small p-value, like 0.03 or 0.001, means the difference is unlikely to be from random chance. Reject the null hypothesis, a large p-value, means the difference could easily be due to chance. Fail to reject the null hypothesis. Most studies use a cutoff of 0.05. If p less than 0.05, the evidence is strong. After calculating the p-value, scientists make a decision. If p is less than 0.05, reject H0, the protein test works. If p is greater than or equal to 0.05, fail to reject H0, not enough evidence. But scientists can still make mistakes. Type 1 error, rejecting H0 when it was actually true. Thinking the test works when it doesn't. Type 2 error, failing to reject H0 when the alternative is true. Missing a test that actually works. Good study design and large sample sizes help reduce these errors. Besides p-values, scientists often calculate a 95% confidence interval. For example, if the difference in M-izime levels is estimated to be between 50 and 70 units, the interval tells us the difference is real. The test has a strong effect. The estimate is precise. Confidence intervals show the size of the effect, not just whether it exists. Imagine the results show M-izime equals 80 units in heart attack patients. M-izime equals 20 units in non-heart attack patients. P-value equals 0.001. This means the probability that this difference is due to chance is extremely low. The null hypothesis is rejected. The new protein test is effective. This entire process, from forming hypotheses to making a final decision, is the foundation of evidence-based medicine. It ensures that new treatments, tests, and medical technologies are backed by data, not guesswork.